Hello everyone, welcome back to my YouTube channel. This is our second lecture on leukemias. In my previous lecture, I have talked about acute lymphoblastic leukemia and acute myelogenous leukemias. In today's lecture, we will cover chronic lymphocytic leukemia, hairy cell leukemia, and acute myelogenous leukemia. Okay, and first, you should know the difference that acute leukemias and chronic leukemias. Acute leukemias are those leukemias that leads to the proliferation of blast cells or immature lymphoid or myeloid cells. Chronic leukemias are those leukemias that leads to the proliferation of more mature cells, not blast cells. Okay, this is how we differentiate or classify it into acute and chronic, either lymphoid or myeloid leukemias. Okay, so let's start with chronic lymphocytic leukemia or small lymphocytic leukemia. It is the most common adult leukemia. CLL is the most common adult leukemia. It is seen in elderly population around the age of 60. Okay, and it is the proliferation of mature B lymphocytes, malignancy of mature B lymphocytes, and those B lymphocytes will be CD19, CD20, CD23, and CD5 positive. These CD19, 20, 23 are the B cell markers. These are the markers of mature B cells. So those neoplastic B cells will be CD19, 20, and 23 positive. Usually, this disease is asymptomatic and it progresses very slowly. Okay, the best initial test to diagnose CLL is CBC with smear, and that CBC with smear will show smudged cells and mature lymphocytes. Okay, so when we will do the CBC with smear, that CBC will show mature lymphocytosis. Okay, mature lymphocytosis means mature B lymphocytes. We will see increased number of mature B lymphocytes, and we will also see pathognomonic smudge cells. Okay, smudge cells, you should remember that CLL, smudge cells. Okay, together, because this is the pathognomonic finding of CLL. Smudge cells is the pathognomonic finding of CLL. Okay, so what are the smudge cells? Smudge cells are, these are the fragile leukemic cells which are crushed by the slide. So smudge cells we will see in the peripheral smear. In CLL we will see smudge cells. Okay, now first important thing is elderly population. Okay, CD19, CD20, and CD23 positive. Second important thing is smudge cells, and third is richer transformation. Okay, richer transformation is what? CLL transform into an aggressive lymphoma, most commonly transformed into diffuse large B cell lymphoma. Okay, the best or the most accurate test to diagnose CLL is flow cytometry. Again, that will show monoclonal B cells with CD19, 23, and CD5 positive. Okay. Now let's talk about hairy cell leukemia. Again, hairy cell leukemia is a malignancy of mature B cell. One, okay, well differentiated mature B cells. Second, it is most commonly seen in older population around the age of 50 to 55, just like CLL. CLL was the malignancy of mature B cells. Hairy cell leukemia is also the malignancy of mature B cell. Both conditions are seen in both malignancies are seen in adult population. Okay, the type of mutation we see in hairy cell leukemia is BRAF mutation. You should remember this, associated with BRAF mutation here. Okay, and now what happens is, what are the features that we see in hairy cell leukemia? So the leukemic cells or penetrate or infiltrate the bone marrow. When there is a bone marrow infiltration and cytokine production in hairy cell leukemia, it causes bone marrow fibrosis and bone marrow failure. When the leukemic cells infiltrate the bone marrow, it lead to bone marrow fibrosis. and then it will lead to bone marrow failure. Whenever there is a bone marrow failure, it results in pancytopenia. Pancytopenia means anemia, leukopenia, and thrombocytopenia. Then we will see the features of anemia like weakness, fatigue, shortness of breath. Then and we will see the features of leukopenia, that recurrent infections. We'll see the features of thrombocytopenia like bruising or petechiae. Okay, so these are the features that are related to pancytopenia. When um, these leukemic cells infiltrate the splenic red pulp, spleen, when these leukemic cells infiltrate the spleen, it results in massive splenomegaly. Okay, so these are the features of hairy cell leukemia. Penetration of infiltration of the bone marrow that leads to marrow failure, one, that leads to pancytopenia. Infiltration of the spleen that lead to splenomegaly. Okay, so the patient will present with weakness, fatigue, petechiae, burning, infection, abdominal pain due to splenomegaly, early satiety, and weight loss. So these are the features we see in hairy cell leukemia. Lymphadenopathy is rare. So the important or high yield points related to hairy cell leukemia is bone marrow failure, pancytopenia, splenomegaly. Lymphadenopathy is rare, is uncommon. Okay, best most initial test or the best initial test to diagnose hairy cell leukemia is CBC with smear again, and that CBC with smear show hairy cells. In CLL, in the smear we see smudge cells. In hairy cell leukemia, we see hairy cells. So these are hairy cells. These are the mononuclear cells with many cytoplasmic projections. Go and Google it. These images are very important. Let me show you the image of smudge cells and hairy cells. So these are the smudge cells. Look, these are the fragile leukemic cells. Image B. Okay, and C is hairy cell. Look, these purple cells with projections. These are the projections. Okay, these are the projections. So these are the hairy cells. So, what we see in the smear, we see hairy cells. These are what? Hairy cells are mononuclear cells with many cytoplasmic projections. And these hairy cells are tartrate resistant acid phosphatase or trap positive. Okay, hairy cells are trap positive. Okay, the most accurate test to diagnose hairy cell leukemia is flow cytometry. Okay, the treatment options, most likely we give patient purine analogs, cladribine, and pentostatin. These are the treatment options for hairy cell leukemia. Now let's talk about CML, chronic myelogenous leukemia, because I've already talked about acute myelogenous leukemia in my previous lecture, that the pathognomonic finding is all rods, and we have already talked about APL, also called M3 type of AML. Go and check out that lecture, it is very high yield. Now let's see ML. The peak incidence is 45 to 85 years, again seen in most likely adult elderly population. Median age is 64. It is defined by Philadelphia chromosome 922 translocation BCR ABL proto-oncogene. This is very, very high yield. Philadelphia chromosome, CML. Okay, and a myeloid stem cell proliferation. It presents with dysregulated production of mature and maturing granulocytes. Granulocytes means myeloid cells. We'll see neutrophils, metamyelocytes, myelocytes, and basophils in the peripheral smears. Look at the E image. You'll see neutrophils, metamyelocytes. These are the less mature myelocytes. These are the less mature neutrophils. Metamyelocytes are more mature neutrophils, and then neutrophils. Okay, and we'll also see basophils in the peripheral smear, and we'll also see splenomegaly. CML can transform into AML or ALL, which is called blast crisis. Okay, this condition can transform into ALL or AML, acute leukemia, acute lymphoblastic leukemia, or acute myelogenous leukemia, which is called blast crisis. So, two important high yield points that you should remember for CML is there is a mutation in translocation of 922 translocation, which is called Philadelphia chromosome. Second is blast crisis. CML can transform into ALL or AML. Okay, we the treatment option is BCR-ABL tyrosine kinase inhibitor, imatinib. This is again very important. Three important points. The first is Philadelphia chromosome 922 translocation. Second is blast crisis, and the third is we are giving patient BCR-ABL tyrosine kinase inhibitor, which is imatinib. Okay, a monoclonal antibody. Okay, and and you should know that C richer transformation is seen in CLL, in which CLL is transformed into diffuse large B cell lymphoma, which is aggressive form of lymphoma. Okay, and blast crisis is seen in CML, in which CML transform into AML or ALL. Blast crisis. Okay, now you should also know the difference between chronic myelogenous leukemia and leukemoid reaction. Leukemoid reaction is a type of reaction which we see in infections. Okay, leukemia is a malignancy. Leukemoid reaction is a reaction or a reactive condition which we see in infections. Whenever there is an infection in the body, we'll see increased number of white blood cells. But that doesn't mean that is malignancy. That is a reactive condition due to infection. So you should also know the difference between whenever there is an increased number of WBC, that doesn't mean that the patient has a malignancy of the white blood cell. Patient has a leukemia. It could be a leukemoid reaction due to infection. So you should also know the difference between these two, because in step 2 I've seen the questions related to leukemoid reaction and CML. So whenever the question comes with a increased number of WBC, you should know how to eliminate how to um, make the diagnosis of CML, what things you should see um, in the CML. Okay, so I'm using first stage of step 2 CK that will show. I'm using this table is very high yield to differentiate between leukemoid reaction and CML. In the leukemoid reaction, the cause is infection. In CML, there is a translocation. There is a 922 translocation which between BCR and ABL proto-oncogene, okay, which is called Philadelphia chromosome. Okay, and the leukocyte count in leukemoid reaction is around 50,000. In CML, in leukemias, the leukocyte count is very very high, more than 100,000. Okay, so when the in the question stem, see the leukocyte count. Okay, with that the lab score, leukocyte antigen phosphate, something like that. Yeah, the lab score is high in leukemoid reaction, and the lab score is low in CML. So in the question stem, they can give you the lab score. If the lab score is low, most likely it is CML. If the leukocyte count is more than 100,000, the most likely it is CML. Okay, and in the peripheral smear, we will see more mature neutrophils, more mature neutrophils in leukemoid reaction. Like metamyelocytes are more mature neutrophils than myelocytes. So we will see in peripheral smear, we will see more metamyelocytes than myelocytes in leukemoid reaction. And in CML, we will see more less mature neutrophils will be more in CML. Like myelocytes will be more than metamyelocytes. You got my point? Okay, so in the peripheral smear, if there is more more number of mature neutrophils, most likely it is leukemoid reaction. And if there is more number of less mature neutrophils, then it is most likely CML. Okay, basophilia we never see in leukemoid reaction. Basophils we see in CML. So in the CML, I have that line of first aid where it says in the peripheral smear we will see neutrophils, we'll see metamyelocytes, we will see myelocytes, we'll see basophils. Okay, but myelocytes will be more than metamyelocytes in CML than in leukemoid reaction. Okay, Toxic granulation in neutrophils is seen in leukemoid reaction, but not in CML. Usually, how we differentiate leukemoid reaction from CML by this lab score. Okay, lab score. Lab score is very important. Lab score, if the lab score is high, um, leukocyte antigen phosphate, something like that. If lab score is high, that is leukemoid reaction. If lab score is low, that is most likely CML. Okay, this is all about leukemias. And if you guys have any questions, you can ask me in the comment section. Thank you so much.